Paisley.
My lady, the next witness is Heather Reid.
If you just repeat after me, I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but
the truth.
Thank you.
I don't know how long you've been waiting, but I'm sorry if we've kept you waiting.
Not
Thank you
at
for
all.
your patience.
Thank you, my lady.
Good afternoon, Ms Reid. Thank you for attending the inquiry today and for providing your statement to this module dated the 2nd of June 2025. By way of your background, please, you qualified as a nurse in 1989, and then after a number of roles in 1994, you completed a Master's in Health Services Management. In 2012, you were appointed as a public health consultant within the Public Health Agency on a range of areas, and you remained in post until 2023, when you became Interim Director of Nursing, Midwifery and Allied Health Professionals within the Public Health Agency Northern Ireland. Is that all correct?
That's correct.
The agency was established in 2009, and its functions can be summarised under 3 broad headings: improvement in health and social well-being, health protection, including a lead role in the public health response to major incidents and other emergencies, and service development, which includes working with the Department of Health to play an important role in providing professional leadership to the collective system of health and social care in Northern Ireland. Is that all correct?
That's all correct.
At paragraph 19 of your statement, you say, in normal times, the PHA is responsible for a range of issues in respect of the adult care sector. Can you provide a brief overview of its responsibility towards the sector in normal times?
Sorry, could you repeat that question, please?
Yes, you say in your statement, in normal times, the PHA is responsible for a range of issues in respect of the adult social care sector. Can you give a broad overview of those responsibilities?
In normal stages, so the adult social care sector is commissioned through the Health and Social Care Services Board, also known currently as the Strategic Performance and Planning Group. The PHA would support the commissioning of services for adult social care and provide input through, for example, nursing, professional input from nursing, from allied health professions as well, and also supporting on any issues around communicable disease and for outbreak management and things like that. But the main, I suppose, role prior to COVID would have been around that support for the commissioning of health and social care services.
Now, at paragraph 49 of your statement, you say that as the pandemic progressed and it became clear that a longer-term response was required, some of the work of PHA changed at the direction of the DOH. Were any of those additional responsibilities specifically related to the management of the pandemic in the adult social care sector?
They would have been whenever the surge planning was, during the initial response. Actually, obviously, the PHA would have been involved right the way through from December into January and then through February as well. Whenever Silver response was set up, I think it was around the end of January. Whenever that was set up, a number of cells were created, a number of subgroups were created, one of them being social care and community care, and the care home sector would have been included in that wider remit, and there would have been a lot of specific information and activities around, I suppose, preparing for what was potentially to come. Obviously, there wasn't a huge amount known about the virus at that stage. So a lot of the staff were involved from that early stage, looking at things like infection prevention control, mitigating risks around making sure that adequate training, PPE was involved. And
just focusing on whether there were any additional responsibilities, was there anything new that the Public Health Agency was asked to do?
Not new at that stage.
On the 23rd of January 2020, the PHA stood up the Emergency Operations Centre, the purpose of which was to manage the information coming to the PHA and to ensure that this information was shared with the right people. And you explain that the EOC did not deal with calls from the care sector.
That's correct.
Which instead were redirected to the duty room within the PHA. and the duty room's day-to-day work is in relation to the public health management of infectious diseases of public health significance. And you say it supports care homes, for example, through regular check-ins when an outbreak has been declared. Is that background all correct?
That's correct, yes.
In your statement, you explain that the PHA Health Protection Team, who staffs the duty room, had well-established relationships with care homes as part of their role in supporting them with outbreaks of other infectious diseases like that of influenza. Was the operation of the duty room an effective way to manage calls from the sector during COVID-19?
Certainly at that outset, the decision was made purely because of the existing relationships and understanding that the duty room would have had with the care home sector. There would have been regular contact, and the health protection duty room would have been very much the initial point of contact for any concerns that a care home might have been. So that was one of the reasons why the decision was made at that stage to keep all of the communication coming through the duty room. The vast number of questions did relate to what are the concerns around infection, what does this virus potentially mean for me? So we felt that actually at that stage that the staff who were staffing the duty room were best placed to support care homes in doing that because they knew the context in terms of where they were coming from.
Was there a mechanism by which the concerns that you've just touched upon could be raised from the duty room and escalated to the Department of Health, for example, or other relevant decision makers to inform their response at this time?
Yeah, absolutely. There would have been very, very regular contact with members of the duty room, and there has always been a consultant with oversight for duty rooms. So, in any particular complex health protection questions, there would always have been medical oversight so that they could escalate those issues. Again, there would always have been very, very regular contact, and Public Health Agency is a relatively small organisation and also co-located as well, so individuals would have had very close working relationships generally, so escalation would have been a matter of course and day-to-day, and the regular meetings as well, so that would be an absolutely supported, yes.
And in the event of a future pandemic, is this the structure that the agency would encourage to be used in the future?
I think, that's a difficult one to say for sure, because obviously we don't know what a future pandemic might look like, and I think that decision was made with the best of intentions at the time. I think looking back, what we might do is consider how we might better bring all of the information together with respect to care homes into one individual cell. But again, by the nature of the different teams did actually work extremely well together, and because, as I said, co-located, the information flowed well. People knew each other. Existing relationships were already in place there. So formal structures we might adapt slightly moving forward.
Now, at paragraphs 44 to 45 of your statement, you explain that prior to the pandemic, the agency's Public Health Directorate had a number of staff vacancies, as well as a number of key posts that were filled on a temporary basis. And this related particularly to HP consultants who were involved in work on care home testing, visiting and rollout of guidance. And you also explain there was a shortfall in specialist epidemiological resourcing, and this was a known risk to the PHA in 2019. You go on to say at paragraph 47, despite the level of vacancies within the agency, I do not believe that this significantly impacted on the PHA's ability to support the care sector during the pandemic. Mm-hmm. Would you say there was any impact? And if so, can you give an overview, please?
Yeah, I think it's fair to say that even prior to the pandemic, the PHA was sort of staffed for business as usual in terms of the response to communicable disease and doing that. And there was an understanding that there were some gaps, certainly even before pandemic, and particularly as in the areas that you mentioned. But part of the business continuity process, whenever we became aware that the pandemic was gathering pace and complexity, the organisation quite quickly flexed additional staff. So the staff that you've mentioned earlier on in terms of working in the service development, they were all moved, and the work that would prior been done in different areas prior to pandemic, they were focused into the pandemic. On reflection, there obviously were some changes in leadership as well, but there was a cohort of very senior staff. It's a regional organisation. There was a cohort of very senior staff providing stability throughout that process. I'm not sure that they were hugely different to any organisation across the UK in terms of trying to manage at the outset of what was a very, very difficult scenario.
If we can perhaps have on screen, please, table 2 of your statement, which is INQ 30587-734 at page 12. And this shows the number of calls received by the duty room for care homes in 2019 and 2020. And these escalated significantly, we can see, in March 2020. And over the page at table 3, there was also a sharp increase in the number of respiratory illness outbreaks and incidents managed by the acute response team. And again, we can see that in this table. That document can come down, please. Was there then difficulty within the duty room in those early months managing those levels of calls? And was staffing in the duty room increased as a result?
Staffing was certainly, and the staff were stretched, absolutely they were stretched, but as I mentioned before, other staff in the agency were redirected. So, for example, the staff in the Nursing and Allied Health Directorate, a vast majority of them have registrant backgrounds, so would have had skills and competencies that could easily work in the duty room under supervision as well. All of the registrars in training as well, and I believe there were about 13 in place at that stage, again, all reorientated to support the duty room. So everything was done to try and support and make sure that the duty room was fully functioning in that regard.
Can I ask, please, about the PUSI review? So there was a review that was delivered to the Department of Health in December 2020, and Professor McBride notes in his statement that the view of the PHA was that there was insufficient capacity to manage NHS and care home outbreaks. Were proactive steps taken prior to December to address those issues?
Yes, and indeed, and there were some additional staff. I mean, we also brought in staff from agencies where we could and from other organisations where we could as well, and so staff were drafted in where possible. Since the Hussey report as well, there have been significant changes with, I suppose, enhancements made both in terms of numbers of staff, but also in terms of the governance and reporting arrangements as well. That has all happened since the pandemic.
Now, you explain at paragraph 37 that staff within the duty room had to review and understand new guidance as it emerged. You say cross-referencing it with previous versions to identify where changes had been made and what the implications for care homes would be. Can you help us, please? What specific pieces of guidance are you discussing there?
Thinking, as the pandemic progressed, guidance on isolation, guidance on testing, guidance on PPE. So obviously the detail of the guidance, just the sheer scale and speed that guidance was being changed. PHA really worked off Public Health England guidance as well, and we adapted it locally, usually just through changes to logistics, but the essence of the guidance was from Public Health Agency England, and it really just reflected the changes in terms of what was known about the virus, and as that came through, our understanding came through and guidance had to be amended accordingly as well. So making sure that everybody was over that was quite a feat at times.
Practically speaking, is there any way that it could have been easier for those that worked in the duty room to see the difference in guidance?
As far as possible, that was undertaken, and where new guidance was issued, there was a process at the outset actually to compare them side by side to see what are the differences, and that would have been made clear at daily briefings as well, so that everybody could understand exactly where the changes were and change their protocols and advice accordingly.
Just one final question, please, on this topic, which is HP zone, which was used by the PHA for the management of outbreaks of infectious disease. You explain it was not designed to support the management of large-scale outbreaks. And you say that whilst it continues to be used, work is ongoing to identify and implement a replacement system that would be better placed to use in the future. What difficulties did it cause, and what work is currently ongoing to identify a different system?
Okay, as you mentioned, it's not really fit for purpose. It's again a business as usual. And again, I'm not an expert in this area per se, but the data collected was at care home level, and it didn't allow us to collect surveillance information at individual level throughout the pandemic. And obviously, that's really important if you're trying to understand what the impact has been, particularly in a care home setting, so that you can understand how many people have been vaccinated, how many people have been tested, for example. HP Zone doesn't facilitate that, and it also doesn't facilitate in terms of my understanding about data linkage as well. So making sure that we could look at outcomes.
So something that would have been able to do that would have been helpful.
Exactly, and processes are underway to try and sort that out moving forward.
I understand that Public Health Agency Northern Ireland in non-pandemic times physically attends care homes where there's a particularly complex outbreak, and that this had to be stopped over the pandemic. Did that have an impact upon PHA's ability to manage complex outbreaks of COVID-19 in particular?
Yeah. Now, there would still have been day-to-day conversations with the care homes, and the teams involved in managing the outbreaks would still have had a lot of in-depth conversations. Now, at roughly the same time as well, at the request of the department, trusts were also asked to support care homes. So there was a lot of additional experience and expertise going in. The trust teams as well that were supporting care homes were, again, infection prevention control leads in the trust as well. So they weren't left without that hands-on guidance if that was required, and also had support from RQIA as well at that stage.
Moving on then, please, to infection prevention and control. And the PHANI was a member of the UK IPC cell. To what extent was the IPC guidance issued to care homes in Northern Ireland specifically adapted for Northern Ireland?
Again, it would mostly have been around logistics in terms of where you go to access tests and what the various arrangements would be within Northern Ireland. The actual technical and the scientific aspects of that would not have changed.
You explain at paragraph 151 that the physical environment in some care homes was not conducive to isolation measures, and the PHA worked with care home managers to find solutions to these issues on a case-by-case basis. What sorts of solutions were found?
Well, in some cases that it would just have been whether or not there would have been single rooms or double rooms. So sometimes it would just be about looking at it like that. One of the particularly challenging ones is for individuals with limited capacity as well. So it would have been working carefully with the care home managers as well in terms of what might be feasible or possible for them in those situations.
It's right as well that the PHA placed senior nurses and midwives from the agency into trusts. Do you think that assisted the care homes?
I hope so. I hope so. And again, it was just about trying to increase capacity and expertise and make that available to the care homes as much as possible.
Can we then change topic, please, and talk about the surge plans? And by way of background, in your statement, you say that it was acknowledged by April or May 2020 that it was broadly accepted that asymptomatic spread was possible. Now, the inquiry has heard a lot of evidence about the evolution of understanding on asymptomatic transmission. But would you agree that, in fact, there was ample evidence it was possible much prior to April?
Yes, no, it certainly looking at the evidence that was possible. And I did go back and actually check with the surveillance team, and you will see in the evidence bundle one of the surveillance reports that actually looks at respiratory outbreaks in care homes in Northern Ireland. And actually from between the period of January to March, there weren't any. There were a couple of others in other sectors in Northern Ireland, but there weren't any. Now, that doesn't mean to say that there was no asymptomatic, but given the prevalence and the potential harm that COVID could do, particularly at the outset in that particularly vulnerable population, there was a good indication that it wasn't hugely an issue. That's not to say that it wasn't there, but it wasn't causing respiratory outbreaks that the PHA was able to pick up on or monitor until past mid-March.
But there was an acceptance it was a possibility.
Absolutely.
With that context in mind then, it's right that the PHA was involved in the preparation of surge planning in January and early February 2020. If we can have on screen, please, INQ 303814885. This is a document exhibited by you. And if we can go to page 19, please, we can see the heading discharge planning. It cuts off, but we can see that heading. And then on page 20, we see some details. For example, patients may not be discharged to their first choice of home. And then at the bottom of page 20, it says there is an expectation that hospital discharges of those medically fit for discharge will be expedited immediately. If that document can come down, can we then please have INQ 301200731, page 1? This is the surge plan that's been exhibited by Professor Holland, dated the 13th of March. Can you help with the difference between those two plans?
Now, again, my understanding of reviewing the both plans, the one that's on the screen at the moment was the initial plan that was done at the request of the Chief Medical Officer and had been led by colleagues in the Health and Social Care Board at that stage. Obviously, PHA would have had input into that. That particular surge plan was based on, it was a RAG rating based on staff availability, and there is a section on care homes and discharge towards the end, and it outlines a series of actions that would be taken to try and ameliorate that. My understanding that there were further conversations with the department after that stage, and the blue document, the second one, actually, I suppose, just gives further emphasis in some of the other areas in terms of the pandemic plan, and it's just really a further iteration of the original surge plan. So it really demonstrates, I suppose, the ongoing development of surge planning in those first 2 or 3 months.
If we can then go to page 72 briefly of this document, and you've told us that this document also dealt with hospital discharge, and you've said that Public Health Agency and I would have had some involvement within this. This document can come down, thank you. In your statement, you say at paragraph 99 that the PHA had no input into the original plans for discharge of patients from hospitals into care homes, and a letter was sent to the sector on the 13th of March about this. But in light of the surge plans, did PHA in fact provide advice on this?
I think we would certainly have been potentially in the room. It's difficult for me to say at this stage whether or not. I don't think that the PHA actually had any operational input into those decisions. I mean, ultimately, decision on discharge is a clinical decision made at trust level. The reference to discharges in both of the surge plans were really focusing on social services, because obviously discharge is into a care home is run by social services as well, and the risk assessment is done there. So I suppose the emphasis on the discharge planning was really about augmenting the social services care teams that actually sit, and that team sits within the Health and Social Care Board, both in terms of commissioning and then at trust level as well. So it was really about trying to put things in place to augment, support that process to happen a little bit quicker if possible, but do it safely as well, bearing in mind all of the other aspects of it, working with the clinical teams to make sure that it could be done safely, because obviously we don't want older people in hospitals. It's not a good environment for them to be in either.
If I can perhaps put it this way then, would it be right to say that PHA wasn't involved in the decision itself, but was involved in operational planning if that decision was taken?
I think they would have been in the room potentially, yes.
To combat the risk of potentially asymptomatic patients being discharged into care homes, do you agree that as a minimum there should have been guidance for the sector at this time in the middle of March that all new admissions be isolated?
I think that again, I'm not an expert in that area, so I'll preface it with that. At that stage, whenever this surge planning was being done, we didn't have the information in terms of asymptomatic transmission. It was sort of, I think, the end of the first week in April before that that information became available. So at that stage, we were working on guidance that was really about the extant guidance in terms of how we would manage any infectious respiratory disease.
In the event of a future pandemic where there is the risk of asymptomatic transmission, would you agree that admission to care homes should be isolated?
I would be deferring that to experts in that area.
Was the Public Health Agency NI involved in any discussions about whether there would have been enough tests available at this stage to test everyone on discharge? Or as far as you're aware, is that something that didn't come up?
I'm not sure whether or not I can't tell at this stage whether or not it was discussed. It may have been, but certainly in terms of testing capacity, there was very, very limited testing capacity in March. And you can see that as well as we go on through the testing questions. I'm sure that will come to light.
At paragraph 39, you explain in April 2020, as more intelligence on transmission became available through pre-existing communication channels and reporting process, the PHA became aware of concerns that the region could experience an exponential growth in the number of care homes affected by COVID-19. We touched on capacity within PHA, but did that lead to a step up of resources at that point?
The resources at that stage were, it wasn't I believe that's the paper, the exponential growth paper that you're referring to, the modelling paper. And you'll see that there was some additional information provided by the Chief Medical Officer in his statement around that modelling paper, because the paper didn't take into consideration the wider lockdown and the community spread. But regardless of the scientific aspects of it, the steps in terms of managing the care home outbreaks would have been exactly the same. It would have been about trying to understand the level of outbreaks in the care homes, making sure that they were fully protected where they can, guidance on PPE, infection prevention control. All of the steps that we would have been taking would not have changed.
And were there extra resources placed in the teams to deal with?
In the duty room?
Yes.
In the duty room, again, that was kept under constant supervision.
Now, an operational group was set up to oversee the implementation and monitoring of the regional surge plan for the social care sector. Was that something that had been in place prior to the pandemic and then tailored for COVID-19, or was that a new plan?
That was a new group.
And can you provide a brief overview of how that plan operated?
Is this the plan? Sorry, if I can just get clarification on which plan it is that you're talking
about.
Yes,
the regional surge plan. I think it rated different care homes red, amber and green.
That's correct. So that sort of plan on a page became, and it was really a distillation of the previous surge plans that could be used specifically to support the care homes. On one side it had sort of the principles in terms of mitigation and risk, and on the other side it had the red, amber, green. And that surge plan was really developed on the back of information that was collated jointly between PHA and RQIA on care home status, and it was delivered every single day around that. That group was initially set up informally, again, going back to my earlier statement about the staff working together and being co-located, and that group wasn't formally put in place, I believe, until May.
When it was used, was it something that was beneficial to manage?
It was very, very beneficial actually at that stage, yes.
On the 27th of February 2020, initial guidance for the care home sector was published in Northern Ireland. The inquiry understands this was based closely on equivalent guidance in England.
That's correct.
And it was assessed by the PHA to make any changes required to then make it relevant for Northern Ireland. I think you have briefly touched upon this, perhaps about contact details, for example, but what other sorts of changes were necessary?
And I understand it was largely around those contacts, and that first couple sets of guidance was really about making sure that the care homes had the same information as the PHA in terms of the emerging virus, bearing in mind that the actual clinical management of outbreaks had not changed. That clinical management was still using the extant flu outbreak packs as well, but the guidance that was sent out to the care homes was in an effort to try and make sure that care homes had as much information on the emerging virus as possible so that they could have conversations with their staff and bring them up to speed on that.
The next guidance, I think it was the interim guidance, was
Yeah.
published on the 12th of March 2020. That was the same day that contact tracing ceased in Northern Ireland, is that right?
That's my understanding, yes.
And the guidance that was issued on the 12th of March 2020 said if after assessment the person has a positive test, then a contact tracing exercise will be undertaken by the PHA. You will be advised of any further actions depending on your recent exposure to the patient. So was that guidance out of date effectively as soon as it was published?
Contact tracing for care homes, everything for care homes went through the duty room as well. So the contact tracing wouldn't have been done for care homes in the wider contact tracing centre.
Did contact tracing in care homes continue beyond the 12th of March?
I'm afraid I would have to go back and find out the answer for that for you.
Was the Public Health Agency NI consulted on the 12th of March interim guidance?
Yes, there were.
Moving on to the next guidance for care homes, which was published on the 17th of March, along with guidance for domiciliary care providers on the same date. Both had been circulated to the Public Health Agency for comment. Who was taking the lead on care home guidance? So who would effectively have the final say on the version that was published?
In terms of the Public Health Agency?
The care home guidance, was that the Department of Health?
It was
an
the
individual?
Department of Health. Department of Health.
Now, that guidance said nursing and residential homes are not expected to have dedicated isolation facilities for people living in the home, but should implement isolation precautions when someone in the home displays symptoms of COVID-19 in the same way that they would operate if an individual had influenza. If isolation is needed, a resident's own room can be used. Ideally, the room should be a single bedroom with ensuite facilities. Professor Hopkins was before the inquiry yesterday, and it's understood that also appeared in the equivalent Public Health England guidance. And she was asked, do you think this was sufficiently clear for care homes when it was drafted for dealing with people where they had symptoms of COVID-19? And her answer was, I think looking at this now in isolation, I'm sure we could improve the clarity. Is that something you would agree with? Could that clarity have been improved?
Yeah, I would agree with that, and I think that's true against a lot of guidance, but in the context that this was being developed at pace, at scale, in a very, very complex area, and I think that's probably reflective of a lot of guidance developed in that manner, where we would normally take a much longer period to make sure that every word was correct.
Can I please now turn to the expert advisory group on testing? You explained this was convened by the Department of Health, but it was chaired by a member of staff of the PHA. Is that correct?
That's correct.
Was PHA, prior to this, asked for any advice on the first interim protocol for testing, and that advised that staff working in care homes were not included in the definition of a healthcare worker?
Not to my knowledge, but I can go back and check for that for you.
Was the Public Health Agency asked to provide advice on version 2 of the interim protocol for testing? That was operational from the 28th of March, and that enabled testing of care home staff who were symptomatic or isolating if a member of their household was symptomatic.
Because the chair was involved and there were other people from the PHA involved in the expert advisory group on testing, I would assume that, yes, they were included in that.
If they weren't consulted, so members of the PHA were not consulted on those pieces of guidance, should they have been?
I suppose my expectation is that there would have been informal conversations, and again, I can't say for sure, but I would expect there to have been informal conversations between the health protection consultants and the expert advisory group on testing.
Can you help with the date that a symptomatic care worker could first receive a test?
Oh gosh, care worker, I actually would have to check. I'm sorry, I don't know at this point in time.
We've discussed that the first interim protocol for testing was the definition of a healthcare worker did not include care homes, so it would have been beyond the 20th of March. Is that right?
That's likely.
What about symptomatic residents in a care home?
Symptomatic residents, outbreak testing would not have changed throughout, so that would have been the same as pre-COVID. So there would be a requirement in care homes to notify the duty room if there was any symptomatic resident, and they would then do a risk assessment to see whether or not it merited an outbreak. And throughout the entire pandemic, that would trigger a request for testing, and obviously when it became available, that testing would have included the COVID tests as well.
So an early stage with that?
Early stage,
Okay.
that would have cased. And obviously for symptomatic staff, again, the same advice would have applied in terms of don't come to work if you're symptomatic, and actually that would have maintained, and I can come back to you with the date for that.
You confirm in your statement at paragraph 102 that on the 10th of April, the EAGT recorded its first discussion on care homes. The first probable outbreak of COVID in a care home in Northern Ireland was on the 16th of March. So would the PHA accept that that was a delay and that conversation should have happened earlier than the 10th of April?
Could you repeat that question again, please?
Yes, so the first probable outbreak of COVID in a care home was the 16th of March. The first meeting of the expert advisory group on testing that discussed care homes was the 10th of April. So would you accept that that was a delay and it should have been discussed earlier?
I suppose it's very difficult to tell at this stage or surmise that other conversations hadn't happened in between. So whilst it may not have been minuted, there may have been conversations in the background. But again, I can't confirm at that point.
Now, that first discussion within the group recommended all symptomatic care home residents be tested when there was a suspected outbreak. On the 18th of April, the Public Health Agency Northern Ireland, along with the other devolved health agencies, attended a meeting with Public Health England, and they discussed the Easter 6 study. And that study concluded that symptoms are poorly predictive of infection, therefore a poor trigger for control measures. And in fact, you mentioned in your statement that the PHANI itself conducted a surveillance study which highlighted that testing only symptomatic residents and staff would not identify all individuals with COVID-19. Version 3 of the testing protocol, which was dated the 19th of April, did not extend testing for asymptomatic residents. My question is whether that then was purely a decision based on capacity.
At that stage, probably it was at that stage.
On the 17th of April, the expert advisory group recommended all hospital patients must be tested 48 hours in advance of discharge to a hospital. That was incorporated into the 19th of April protocol. Is that your understanding?
That's correct, yes.
Can we please have that on screen? INQ 30103-724, page 3. And we can see in bold, this new testing requirement must not hold up a timely discharge. The information from the test results with any supporting care information must be communicated and transferred to the relevant home. Some care providers will be able to accommodate individuals with a confirmed COVID-19 positive through effective isolation strategies or cohorting policies. If appropriate isolation or cohorted care is not available with a local care provider, the local HSE trust will provide alternative appropriate accommodation and care for the remainder of the required isolation period. This alternative accommodation should also be used in the exceptional cases of test results not being available at the point of discharge. Is this referring to the use of step-down or designated setting facilities?
I believe so.
Should arrangements for isolation in facilities where care homes cannot effectively isolate people have been put in place in mid-March, when the decision was taken to expedite patients into care homes?
Quite possibly, but it's difficult to, I suppose, it really, I suppose, around the timing and the capacity and being able to identify such areas.
Thank you. That document can come down. On the 24th of April, you confirm at paragraph 108 that whole home testing was introduced for care homes with a new outbreak. So by the 24th of April, it was no longer restricted to those with symptoms. Would that have been because there was an increase in capacity or something else?
There would have been an increase in capacity.
Do you know why at that date it was only for new outbreaks?
I'm afraid I don't.
Updated guidance was issued to care homes on the 26th of April 2020. The inquiry understands this is the first date that all discharges from hospital, whether negative or not, were to be isolated for 14 days upon discharge. Is that correct?
That's correct, yeah.
And I think your answer earlier was that you would have to defer to somebody with the expertise as to whether that was something that was beneficial. The care home guidance had not been updated then between the 17th of March 2020 and the 26th of April 2020. Given the policy changes that impacted on care homes between those dates, would you agree that further iterations would have been helpful?
I think I would concur with that.
Moving then to the impact of the discharge decision, and you explain at paragraph 111, the PHA would accept that some care home outbreaks of COVID-19 were as a result of the movement of people from hospital to care homes, although these were likely a small minority compared to the larger number of outbreaks that arose from the normal connections between care home residents, staff, visitors and the wider community. Do you agree, though, that given the limited testing that was undertaken in the early months of the pandemic, it's difficult to draw a firm conclusion?
Absolutely, it was impossible to draw a firm conclusion.
And alongside the discharges into care homes, what, in the view of the Public Health Agency, were any other pathways?
Well, obviously, care homes are busy institutions, and there would have been staff moving in and out. And we do know that from the evidence that there were certain particular variables that caused an increase in risk associated. So larger care homes where obviously there was a higher degree of footfall, where there was a significant change in staff, an increased use in bank staff that may not have been familiar with it. There would have been a whole potential range of ingress into care homes where ideally we would try and manage it, but there were possibilities. So it would have been very difficult to understand if an outbreak had happened, very difficult to pinpoint the exact method of ingress.
Going to move on, please, to May 2020, and on the 18th of May, Robin Swan confirmed that testing was to be made available to all care home residents and staff across Northern Ireland.
That's correct.
He said, our intention is to complete testing of all care home residents during June. Had there been greater capacity, should that have been brought in earlier if capacity had allowed?
Again, I wouldn't have the technical experience to make that determination.
You explain that on the advice of the expert advisory group, a revised testing policy was introduced in all COVID-19 free care homes, and from the 3rd of August 2020, staff would be tested every 14 days and residents every 28 days.
That's correct.
Now, the inquiry understands that this regular testing was later than both England and Wales by some weeks. Can you help with why it was later?
I'm afraid I can't, but I can certainly find out for the inquiry.
At paragraph 121, you say the PHA's evaluation indicated that proactive asymptomatic testing reduced the length and severity of outbreaks seen in care home settings. Mm-hmm. Would it then be fair to conclude that if capacity had allowed, it would have been sensible to do that testing as soon as practical?
That would seem reasonable.
Moving then on to a few general comments on guidance, please. You explain in your statement that during the pandemic, the PHA did not have the capacity, expertise or access to the most up-to-date information to attempt to produce technical guidance from scratch.
That's correct.
Generally, guidance from PHE, UK HSA and other devolved nations was amended to reflect NI structures. Can you help us, please? If there had been more resources, do you think that they would have been significantly different, or was it the same outcome was still achieved?
I suspect the same outcome would have been achieved. Northern Ireland participated in Four Nations meeting in respect of all of the mitigating areas for COVID as well. And there is also some real benefit in making sure that there is similar guidance across the Four Nations in terms of continuity of advice and support for the care home sector.
Going to move now and ask a few questions about PPE, please.
Okay.
On the 26th of March 2020, a meeting took place between the Department of Health and independent sector providers. Can we have on screen, please, INQ 30508447? On page 1, providers advised they felt the extant guidance from PHA was insufficient and unhelpful, and that the department need to exercise control around media messaging. Had the PHA issued any additional guidance beyond that of the 17th of March care home guidance, and does the PHA accept that criticism?
Well, obviously it's very difficult because the PHA wasn't represented at that particular meeting, so may have been able to provide some different advice or context or address some of the concerns at the time. I am conscious, however, in preparation for giving evidence today, that the very initial guidance around PPE was particularly acute focused, and it did take a little bit of time to try and develop that and make it much more community focused at that point.
When you say acute focus, what does that mean?
As in hospitals.
Hospitals. So could more have been done, do you think, to provide guidance tailored to care homes?
I think potentially yes. But again, scale, doing things at speed.
That document
reflects
will come
that.
down, thank you.
Thank you.
A rapid review was undertaken of PPE and a final report was submitted on the 14th of May. And Professor Holland outlines that one of the actions taken forward was assurance from the independent sector to PHA through the relevant HSC trust that systems were in place to manage supply and that PPE was being used in line with the guidance. What assurances were necessary?
I think this was just a reflection of trying to make sure that, because trusts had been asked to support care homes with their PPE and in terms of supply for PPE as well. So it was just really, I think, an assurance to try and make sure that everybody was doing the same thing and adhering to guidance in terms of best practice use, donning, doffing, disposal of PPE as well, and just trying to make sure that everything was in order around the guidance.
A few questions, please, then, on visiting.
Okay.
Now, the agency played a lead role in the development of the Care Partner scheme. What was the intention behind the scheme?
The Care Partner scheme was really intended on the back. There was a rapid learning initiative done in the summer of 2020, triggered by the Chief Nursing Officer at that stage. And it was really on the back of that as an effort to try and support residents and indeed families in care homes. This was over and above testing, over and above visiting as well. And it wasn't suitable for all residents or indeed all care homes, but it was really an initiative whereby a pre-existing member of a family or a friend, where a resident would have additional needs such as support for social isolation, eating, drinking, encouragement, that they could provide additional support, working closely with the care home as well, so they had additional training and could I suppose, visit the care home regularly to provide that initial support. It started in September, and care homes were all asked by, I think it was the early November, to make sure that that was in place. And then RQIA also did some monitoring around visiting and the use of the care partners, but I believe it was widely expected or accepted and widely used.
The inquiry understands that there were some difficulties in implementation of it. Was the PHANI involved in implementation?
They were involved in terms of encouraging it, and there were regular conversations and contacts with between the PHA and the independent sector and representatives. So it would have been very much the PHA would have been involved in encouraging and supporting. And if there were any sort of questions around it, they would have had conversations with the care homes and with RQIA to try and I suppose put right any issues.
What thought should be given to using this type of scheme in the future?
I think certainly in terms of the feedback and reflection, it was well received, and it actually seemed to work extremely well. And in particular, moving forward, care home or care partners were also included in the testing as well, and similarly to staff as well. So I think it actually worked very well, and certainly the feedback that we have received to date would indicate the same.
It's right as well that the PHANI was asked to lead on the development of the normalised visiting forum. Can we have on screen, please, INQ 30s 591869? This was a briefing paper produced by the PHA NI. And on page 2, the first paragraph, it says, the approach agreed must continue to protect care homes from the introduction of COVID-19, but also enable family caregivers and visitors to provide much needed contact, support and care to residents to maintain and enhance their overall health and well-being. Now, you say in your statement that this was done at an appropriate juncture. However, do you think in the future thought could be given to something like this earlier?
I think it's such an important, visiting is perhaps one of the most challenging, complex and important areas, because it's really about managing risk, and it's about balancing the risk of infection towards that vulnerable position or vulnerable population, along with the potential harm due to isolation. So actually it's a really important issue, not just for the pandemic, but actually moving forward in terms of care home management and support for care homes much more generally. So I think it's a really, really important area. So
this is something you would encourage to be
Absolutely.
considered perhaps from the outset of a future pandemic?
Absolutely. As I said, not just for pandemic, actually much more visiting. You know, outbreaks do happen, unfortunately, in care homes, respiratory winter viruses, and I think it's really important throughout all of those scenarios.
Thank you. That document could come down. You explained that the forum included representation from families, trusts and so on.
That's correct.
Generally speaking, with respect to visiting in particular, what is the importance of that engagement with stakeholders?
I think the importance with stakeholders in terms of visiting policy.
Yes.
No, it's hugely important, absolutely hugely important. And in fact, I don't think that you can do it without that full engagement. And indeed, there was a survey conducted by all of the stakeholders that you've mentioned. And you can really see the disparity in terms of opinion. And it's really difficult and challenging to get one size fitting all, because we had, on one hand, some relatives who were wanting to visit more, and other relatives at the other end of that spectrum who were very keen for isolation and protecting their loved ones at all costs. And so it's really important actually to make sure that we have that breadth of views, so that everybody can be around the table whenever you're trying to develop the frameworks.
And again, would you agree it's important to have that from the outset?
Absolutely, where possible.
3 more very brief topics, please. The first is data collection. Did the Public Health Agency have access to definitive data regarding how many people were in receipt of care in the social care sector?
No, and that is a particular gap.
And would it have been helpful?
Absolutely, absolutely.
Did the agency have access to definitive data regarding how many people at any given time worked in the sector and what their roles were?
Again, no, we didn't have details on the numbers.
Again, would it have been helpful?
Absolutely.
Were there any particular difficulties in reporting of deaths data within care homes, and can you give a brief overview of those?
That's quite a complicated area, and I suppose NISRA is the Northern Ireland Statistics Research Agency is a definitive guidance, but it takes there's a little bit of a delay.
Perhaps if I can cut through it.
Yes, of course.
Is it the case that NISRA has the responsibility, however the Public Health Agency were asked to report on some deaths rapidly?
They were, but those were largely in the acute sector, again in hospitals, and medical practitioners were asked to report deaths on a daily basis. In the care home sector, deaths also have to be reported to RQIA as well, but just the way that the information is collated on deaths data is quite difficult to understand why the reason, obviously, in that population deaths would not be that uncommon. So it was quite difficult to tease out exactly which deaths may have been associated with COVID and which may not have been associated with COVID.
In the view of the agency, who should be the body that collects that data and provides, if it were a single source, that decisions can be made upon?
I think it would be NISRA.
Training provided to care homes, please. You explained that a number of echo and Zoom sessions were facilitated by the PHA to support care homes, and they covered topics such as the role of the regulator, environmental cleanliness, and balancing the risks and rights of visiting. Did the PHA receive feedback on those sessions?
We did a little bit, both at the sessions and also afterwards, and they were extremely well received.
Can you help with what sorts of issues were covered particularly in the session on visiting?
Everything that you might imagine as well, in terms of how it can be done safely, how it can be ramped up quickly, how it can, PPE, anything that you can imagine was discussed. The sessions were very well attended. There could have been upwards of 160, 200 care homes at any one of those sessions. So the questions were wide and varied across all of the aspects associated with visiting.
Now, of course, we've talked about the limited resourcing of the PHNI, particularly at the beginning of the pandemic, but with adequate resourcing, would the PHANI put on more of that training in the future? Was it helpful?
That training had happened before the pandemic. It was just tailored. There was a specific resource identified by a previous director of nursing in the PHA to identify a very senior nurse who actually used to be a director of nursing in RQIA as well, who had well-established networks and had started to develop programmes for training for care homes, and that was on the back of a report from Coppney previously. So the actual process, and that's one of the reasons why I think the training bit helped, and we were able to hit the ground running because the systems and processes had already been put in place, but they were incredibly valuable and a very good way of getting training and allowing feedback that ordinarily would have been much more difficult in terms of, for example, we spoke about earlier about actually writing guidance, and it facilitated because 3 or 4 people would be able to go on and have conversations there and then, and questions with care homes, and allow for clarity, questions, sharing information and sharing experiences. So it was incredibly valuable.
And so I think you would agree, if there was the resourcing there, and even more training would be something helpful.
Absolutely, very much so.
2 short questions on domiciliary care workers before I move to final reflections, please. At paragraph 116, you state the PHA acute health protection response did provide support to domiciliary care agencies. However, the agency did not have access to accurate data in respect of those receiving care and those working in domiciliary care from which to assess impact. As with other data that we've talked about, would it have been helpful to have more data? And who would collect that data?
I'm not sure on the exact answer to that. On the background of the Hussey report, one of the areas that was identified as a gap was actually data, digital and intelligence, and there is a new directorate in the Public Health Agency going to be focusing on that, so I would expect it to sit within that directorate moving forward.
Can you give just a brief overview of what support the PHA did provide to domiciliary care providers, please?
Certainly, in terms of information given to care homes would also have been provided to those providing domiciliary care. A lot of information would also have filtered down through the trusts in terms of domiciliary care, and testing as well in terms of asymptomatic testing would have been in line with the wider community setting as well, but symptomatic testing for domiciliary care would have also happened through the PHA. So a lot of the guidance that would have been sent to care homes would also have been shared wider with domiciliary care providers through RQIA.
Is there scope for ensuring that guidance that is provided to the domiciliary care sector is specifically tailored to domiciliary care?
Ideally, yes.
You just touched upon testing there briefly. The inquiry understands that regular testing of asymptomatic domiciliary care workers was not available until August 2021. Would you agree that was too late?
Again, I would have to take technical advice on that one.
Can I then ask just for some final reflections, please? Can I ask if you can reflect on the wider experience of the pandemic, particularly with a focus on the impact on the adult social care sector? And you say at paragraph 88 of your statement, there is learning for the PHA, and looking back, it was the case that the agency's support to the care sector was being managed largely through 2 different directorates, in which a number of discrete work streams were being progressed, such as visiting, testing and the day-to-day support being provided by the duty room. An alternate model in which a senior member of staff had oversight of the entire care home response may have provided a better approach to the care sector within the agency. Can you please give a brief overview of what the problem was and how it could be resolved?
And again, I think it's just, again, it's obviously easier to look back with the benefit of hindsight in terms of what might have worked better. But I think that there would have been opportunities for us actually to bring all of the information related to care homes in under one single group with a role of one or two people actually with having oversight of all of that information in one place. We were probably over-reliant on having close networks and close working relationships. So it wasn't that the information wasn't shared, but the formal structures didn't always, I think, reflect that.
Has there been any restructure to reflect that?
There has been a significant restructuring across the whole of the agency on the back of the Hussey review, which was very much welcomed and very much a catalyst for doing that.
So in terms of structure and resourcing, both of which were acute problems, is it your opinion that those matters have been resolved as best they can, or is there room for further improvement?
I think there's always room for improvement in any scenario, and it's always very difficult to get that balance between working effectively in a business as usual and also in preparing for what the next major incident might be. Obviously, this was one of the biggest events that any of us will ever see in terms of a public health emergency. So it's really quite difficult to balance that, but certainly I think that the new structures that are in place very much support and address that.
And just finally, other than any matters that we've already touched upon, are there any other significant recommendations or lessons that you think it's important that this inquiry considers?
I think the matter of data that we've already done and that ability to understand and have live access to information in the care home sector, and there are certainly ways that Northern Ireland has an Encompass system, which is a new electronic system that's live across all of the trusts now, but it's very much linking that information with the care home data sets and using things like honest broker services to make sure that there are no data breaches in that as well. I think areas like that and the digital and data infrastructure obviously would be a major part of that. I think there's also something about how we commission and plan for services for older people more generally. Care homes are obviously an important aspect of that as well, but I think the lessons from this are much, much wider. In society, the care home population, we think of that as a bubble, but these are people who have spent their lives working as members of society and really deserve that respect and that encouragement and that focus. So I think that the learning around how we balance risk, I mean, I have personal experience of that as well, and I can only imagine how difficult that is for individuals whenever you are separated from a loved one. I can only imagine how difficult that was during the pandemic. But the learning and the reflection that we've had, both personally and within the agency, goes much more beyond that. So the new structures in the agency, we look at a life course now with one of the main areas about living well into older age as well. So the lessons are much wider than just for the pandemic. I think it's really important that we focus on getting the lessons embedded into this in our day-to-day lives and our day-to-day worlds, not just for the pandemic.
Thank you, my lady. I have no further questions. I think there are some core participant questions.
Thank you very much indeed, Ms Paisley. Very grateful. Mr Wilcock.
Thank you.
Good afternoon, Ms Reid. I'm asking you questions on behalf of the Northern Ireland COVID bereaved Families for Justice. And my questions are all based on evidence that the inquiry has heard from the Office of the Commissioner for Older People. And the first question can be prefaced in this way. In your statement, you observe that during the pandemic, the Commissioner for Older People shared information with the PHA, which the PHA used in carrying out its functions. Now, both the then Commissioner, Eddie Lynch, and the Chief Executive of the Older Persons Northern Ireland, Evelyn Howe, have stated that when, on the 16th of March 2020, the Chief Executive of the the Older Persons, Commissioner for Older Persons Office Company, highlighted the alarming number of elderly individuals contracting and dying from COVID in Italy, which we will all remember from the news, as at the 16th of March. The response from PHA, they have said, was characterised by what they describe as an air of unreality about the possibility of the reported high numbers of deaths of the elderly in Italy ever happening in Northern Ireland. Question is this: are you able to comment on Mr. Lynch and Ms. Hoyle's evidence that the PHA expressed the view that, and I quote, "that won't happen here. They have a completely different system over there," as Ms. Hoyle raised the possibility in the meeting?
I suppose there's two points to my answer to that. Is one, and I've looked at both those sets of evidence, and in one statement it says that it was the PHA, and in the other statement it said that it was a member of the Department of Health that actually had made that statement. So I can't, not being present at the meeting, I can't verify the context, but the more important aspect of it is PHA was involved right from the very beginning in Four Nation conversations with WHO, the rest of the Four Nations, and watching the evolution of this, as they would do with any new virus of note. With the evolution, those conversations were happening on a day and daily basis. There was a very, very real understanding of what the potential that this could happen in Northern Ireland, and that was one of the reasons why there was Silver was set up very early in the PHA as well. Locally, we're extremely concerned about what the impact that COVID could potentially have for all of Northern Ireland.
Thank you very much. Second question, again based on their evidence.
Okay.
Mr. Lynch has observed that the guidance issued by the Department of Health on the 17th of March, the COVID guidance for nursing and residential care homes in Northern Ireland, contained little on testing for COVID-19, and in contrast with the position in England, predicated the involvement of the Public Health Agency dedicated team with a care home, quote, in the events of one or more residents testing positive for COVID-19. And you will have read that in his statement. Do you agree with him that the weakness of that approach was that it presupposed that testing facilities had by then been made available in care homes in Northern Ireland?
Yeah, and again, I think there's maybe something lost a little bit in translation, and it probably should have been made clearer in the guidance. But the testing that Mr. Lynch referred to in England was outbreak testing, which was already actually available in Northern Ireland as well. As I mentioned earlier on, that didn't change right from the outset. So whenever there is any symptomatic case of respiratory illness or disease, obviously we came to know that as COVID quite early on in March. But even before then, that didn't change at all in Northern Ireland, and that would have been part of the extant guidance. Care homes would have been in touch with the Public Health Agency. They would have done a risk assessment, and depending on that risk assessment, up to 5 symptomatic residents would have been tested. And obviously, whenever the COVID test became available in Northern Ireland, that would have been included in that suite of tests. So that absolutely was available in Northern Ireland at the time. Now, I think it may just have been a gap in terms of the information that was provided in the guidance, but at that stage, the extant, I suppose, guidance for managing respiratory illness remained in the Public Health Agency duty room. So there wasn't any difference between Northern Ireland and England in that regard.
So you spoke earlier on about the clarity of some of the guidance. Does Mr. Lynch's confusion to this guidance underline perhaps that it wasn't as clear as it could have been?
Absolutely, I would absolutely take that on board. Without a doubt.
Final question. According to Mr. Lynch, the Public Health Agency's website at this time stated that, and I quote, testing is currently limited to patients who are being admitted to hospital and some, I can't read my own writing, and some healthcare workers. Is Mr Lynch justified in telling the inquiry that this approach confirmed his concern, and again I'm quoting, older people in care homes would only be tested if their symptoms progress to the extent that they are admitted to hospital, as there was no effective means for having them tested prior to that, and that at this stage there was resistance from officials from the Department of Health to the testing of staff and residents in care homes, consistent with the Minister having been briefed that this was not necessary?
Well, as I've outlined earlier on, there would have been, for symptomatic testing in a potential outbreak scenario, would have been available. But the other thing to bear in mind in terms of the testing capacity and availability at that stage, at the outset there was about 40 tests a day available, moving to about 200, and that was for the whole of Northern Ireland as well. So testing at the beginning was very much limited to those in critically ill, to support clinical decision making around that, and largely would have been done in hospitals, but some of that would have been done to support symptomatic testing in care homes as well.
And you will appreciate I'm asking you about Mr Lynch's understanding.
Absolutely.
Does it come to this, he's misunderstood again?
Well, it's not necessarily his misunderstanding. It may have been just in terms of the guidance not have been clear.
Thank you very much. I was going to ask you one more question, my lady, but Ms Paisley's already covered it more than adequately. So I'm not going to ask any questions.
Thank you very much, Ms Wilcock. Ms Beattie, I think. Over there.
Hello.
Ask questions on behalf of disabled people's organisations. You've been asked already by counsel to the inquiry about testing of asymptomatic domiciliary care workers, which you told us wasn't brought in until August 2021, yes?
That's correct.
I understand that's about 9 months after it was brought in England, Scotland and Wales, that made that testing available towards the end of November 2020 and early December 2020. Did the PHA take account of that development in the other nations to consider bringing that testing in sooner?
I'm afraid I don't have the answer to that, but I certainly find out for you and come back to you on that.
Right.
I wouldn't want to give you misrepresent decisions or conversations that already happened. So apologies, I can't answer that question at this point in time, but we certainly will find out and come back to you if that's okay.
Yes. Thank you, my lady.
Thank you, Ms Beattie. That completes the questions we have for you, Ms Reid. I think there are a number of questions where you said you could get back to us. I don't know, have you got somebody who can help you going through a transcript of the evidence?
We will indeed.
I'd be really
Thank you,
grateful
and
if you could do that,
apologies
because
for
I know
that.
there are a number of the questions where, like Ms Beattie asked and others asked and Ms Paisley asked, that we'd quite like the answers to. So
Super, thank you.
thank you very much for your help, and a safe journey back to Northern Ireland.
Thank you so much.
Thank you. Very well, we'll take a 10-minute break. I should be back at 1:15.
All rise.
Ms Lyon, you're our last witness of the week, so thank you very much for waiting.
Thank you.
And I'm sure that from our point of view, it'd have been worth your wait.
I hope so.
Repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
And just so you know, Ms Lyons, as Ms Paisley knows, I've read your written statement. So, we don't and it's extremely moving, an extremely powerful statement. So Ms Paisley doesn't have to go through every detail, so I understand. She'll go through the most important parts, all right?
Thank you.
Thank you, my lady. Good afternoon, Mrs Lyons, and thank you very much for attending the inquiry today and providing your statement. I'm going to ask you some questions about your daughter Sarah and your collective experience as a family over the pandemic. Sarah is in her early 30s, is that right?
Yes.
You outlined this in your statement, but can you please give an overview of Sarah's needs?
Sarah was always diagnosed from the age of 2 with a significant language disorder. Then she was diagnosed with dyslexia, dyspraxia, profound memory problems. So she was always in special provision at school. She couldn't cope in mainstream. And we fought hard for her to get the education that she was legally entitled to and needed, rather than being left in mainstream to fail. At the age of 12, the epilepsy started. And at first, it was just a few absences. It's like a 10-second seizure. And we didn't actually see them, only the school saw them, until I saw a consultant paediatrician, and he elicited a seizure by getting her to blow on a paper windmill. After that, the epilepsy accelerated. She went from absences to 50 focal seizures a day, so probably 350 a week. And by January, she had her first tonic-clonic. I'd never seen a seizure before Sarah, and I'd never seen a tonic-clonic. I didn't know what to do, and we took her to A&E, where she was diagnosed eventually with epilepsy. They gave her a drug, which for 2 years worked. There were no more seizures, and we thought, oh, epilepsy's not a big problem. Then the seizures came back, again accelerating from 10 to 50 seizures a day. She was put on 2 drugs, 3 drugs, 4 drugs in an effort to control it, and nothing did. She was referred first to our local hospital and then our regional centre to see the head of paediatric neurology there for the region. And they tried various things like ketogenic diet, different drugs, none of which really worked. We didn't appreciate how severe her epilepsy was. Nobody told us that this is way more severe than normal. And eventually, the schools couldn't cope with her epilepsy, and we had to look at specialist epilepsy schools. And it was only there we were told she's got the most severe epilepsy here, and we realised she was amongst the most severe in the country. She was under Great Ormond Street.
Thank you for providing that background for us. And against that background, you explain in your statement that Sarah needs one-to-one care as a result. Why is it so important that she receives one-to-one care?
If you saw Sarah in a restaurant, you wouldn't realise there was anything wrong with her. She looks normal, she's lively behind the eyes, she can walk and talk and eat, the same as everybody else. But the question is the seizures. She can have a seizure at any time, fall down, hit her head on that desk, and need to go to hospital for assessment, or she could break a bone. There is also the risk that a seizure doesn't stop. If they go on for more than 5 minutes, they must be stopped with emergency medication. And if that doesn't work, you have to call 999 because hospitals can use intravenous drugs we can't. So it's really about the seizures and the risks that come from them that she needs one-to-one.
And you explain in your statement, though, that Sarah loves life, and her life is just as important to her as it is to everybody else.
Yes, it is. She's always been sunny, warm, happy. She enjoys all the things that people of her age do, like eating out, cinema, restaurants, theatre, and generally she was very happy until the epilepsy went out of control.
You explain in your statement that you have previously been told by a consultant neurologist just how important it is that you are involved in Sarah's care and decisions about her care, and you were told that you were the best people in the world to get her the help that she needs. Why is it so important that you are so closely involved in Sarah's care?
She's so complex. Her epilepsy is going to be more complex than the average doctor in a hospital will see again in their lifetime. And it's not just the epilepsy, it's the added complication of the language disorder. So you need to speak to her in clear, simple language. You can't just use slang, puns, etc., because she doesn't understand. And also, there is really often a tacit attitude in the NHS that NHS resources are wasted on people with learning disabilities, and she wouldn't get as good treatment, possibly, as if we're there pushing it.
Can I move then, please, to the first lockdown in March 2020? And Sarah had been in a care home setting, but I understand she was back at home for her birthday going into the lockdown.
Yeah.
How long was it intended that Sarah would be back at home?
It was intended that she'd be back at home for a week, but because her aunt had died the day before she came home, and we were told the funeral was going to be on the Monday, we intended to keep her home for 10 days so she could attend her aunt's funeral and get closure.
I understand that, of course, events then moved on. You received a letter explaining that residents, including Sarah, who were on home leave, could not return to the care home premises.
Yeah.
What was your initial reaction?
Shock. I was shell-shocked. We had seen Wuhan on the news in January, and we said to ourselves, that is coming here. And we were astonished that the government didn't do anything like ban international travel, that sort of thing. But I didn't know what a lockdown was until the day Boris Johnson announced it. And I never thought that the care home would refuse to have her back when everything until that day had been normal.
Can I deal then, please, with the impact on Sarah's care as a result of her staying within the home? I understand that there was an impact upon the supply of medication that Sarah needed. Can you explain that, please?
Yes. I mean, Sarah had always come home weekends and school holidays throughout her education. And in the school holidays, occasions had happened when she'd broken a bone or she was ill, and we couldn't take her back. So we needed an extra supply of drugs for a week. In case of those eventualities, I had asked them before she came home for an extra week's supply of drugs, and they didn't give me enough. And I knew we were going to run out, given the circumstances of the lockdown. And it's very difficult to get them registered with the GP and get them to prescribe drugs they've never heard of, which are very expensive. And you've got to get documentation to prove that this is what she's on. They don't take my word for it. Then the pharmacy's got to get hold of drugs which they don't keep in stock. They're too expensive.
So how easy or indeed how difficult was it for you to have to spring into action and try and organise all of this in a lockdown?
It was difficult. Registering her as a temporary patient, getting the drugs from my GP, and even when I did manage to get the prescription, my pharmacist couldn't get hold of one of the drugs for about 10 days, and we had no choice but for her to come off it, which I'd always been told could only be done safely in a hospital. Normally the drugs are weaned off very slowly. There were rebound seizures, and which were obviously stressful and dangerous. To take her off abruptly could have killed her.
You explained that Sarah was not counted as clinically extremely vulnerable.
Yes.
Did that cause any difficulties in terms of supermarket deliveries or how you were able to manage with
Yes.
having her at home?
Yes, food for me was the biggest problem. I'd always had online deliveries ever since they started, and suddenly they were all stopped and people who were shielding got priority, which was absolutely right. But I found it very difficult to get deliveries, and I would have to log onto the website at 11:30 at night. The slots opened at midnight. I would sit in a queue on the website until about 1:45, when I would get the choice of a slot in about 3 weeks' time. And considering Sarah was waking us up at 4 a.m. every morning, I was extremely tired.
And you explain in your statement the impact that this lack of sleep, for example, and having to manage Sarah's care one-to-one yourself, the impact that had on you and your husband. Can you tell us a bit about that?
Yes, 2 care agencies had said it was too stressful for one of their care workers to look after Sarah by themselves. They insisted there was either one care worker with me, and if I wasn't there, so I had a hospital appointment, there had to be 2. And while she lives in a care home with one-to-one care, they had to take on 3 care workers to provide that 7 days a week in her waking hours. Well, there was just me. Plus, in her care home, there were about 900 staff. It's not the average care home for the elderly. There are all the medical centre, the speech therapists, OTs, physios, social workers, plus maintenance, IT, finance. So if the staff had a problem with their computer, they just had to ring up IT. If I had a problem, I had to fix it myself. And the same with everything. I was trying to do all of that work while looking after Sarah, who needs full-time supervision.
Can I please ask you about DNA CPR decisions, please? You received a letter from Sarah's GP surgery asking to confirm your preferences. This is the first letter you received. How did you feel when you received that letter?
Well, I was incandescent. As I said, I'd come across in the NHS before this tacit attitude that resources were wasted on her. For instance, they wouldn't pin her collarbone when she broke it. And I just thought this is yet another example of the NHS seeing her as a second-class citizen, and although she has human rights under the Human Rights Act, these are being disregarded, really. And, you know, she was a healthy young woman in her 20s, apart from the epilepsy. And at that time, she was in better health than the rest of us. So I had suspicions that for her, it would be no more than flu. And I didn't see why I should agree to a DNA CPR for a healthy young woman in her 20s.
You explain that you wrote back and explained you didn't agree with the decision until Sarah had a terminal diagnosis. However, you in fact received another letter the year later.
Yes.
Can we have that on screen, please? INQ 3061265. There's no particular question, no particular piece of text I wish to ask you about, but in general, the language, how did you feel that was communicated, such a significant subject in this letter?
I felt it was being dropped on us as if we were going to agree with it. It wasn't a discussion. It was here's a form for you to sign. And I felt it should have been brought up with us and Sarah to get her views. And I just could not understand why somebody in their 20s could not go through CPR. She's she is a well-built young woman, and if CPR is not appropriate for her, then maybe it should be banned altogether. Who is it appropriate for?
And you've just touched on it briefly, but was there any other contact at all over the phone to reach out to you to try and discuss a sensitive topic, or it was just the letter?
Yes. I mean, they did offer a telephone call, but I didn't want to discuss it. As I said, if she was diagnosed with a terminal illness, then yes, we would have been happy to discuss it.
And I think, in fact, you took some action following this
Yes.
that you wanted to draw to our attention. If you can explain what that was.
Yes, I was so upset about it. I wrote to MenCap. They've got a helpline, and I sought their advice, because what worried me was that it was in the news that doctors were applying DNA CPRs on care home residents with or without their relatives' permission. And I was concerned that the doctors would do that and it would be a proxy for no treatment for anything. So I asked MenCap's advice and they asked to see the forms, and I think they were as shocked as I was. And originally they took it up with NHS England, who spoke to the care home and eventually brought it to the attention of the Parliamentary Human Rights Committee. And then NHS England wrote the letter saying this shouldn't be applied to people with learning disabilities and autism. And I was really grateful for that.
Thank you. It's right that Sarah did eventually return to the home that she had been in prior. When was that? What month?
November 2020.
Generally speaking, did the restrictions, in your view, balance the needs of someone like Sarah with Sarah's needs, with the risks that COVID-19 presented to her as an individual?
No, I felt, as I said, none of us knew very much then about COVID, but I had the suspicion that as a healthy young person in their 20s, it might be no more than flu. And in that case, I felt the risk to her from her epilepsy far outweighed the risk to her from COVID. We'd been told by a Great Ormond Street consultant that when she was at the residential school and we spoke to her on the phone in the evenings, we were not to bring up anything stressful. She was worried that Sarah would die in the night from sudden death in epilepsy. So we've always got that in the back of our minds every day. Today she could fall down the stairs and break her neck during a seizure. Tonight she could suffer sudden death in epilepsy. And we've been told she's in the highest risk group. And it seemed to me no attention was paid to the risks from her epilepsy, which for us far outweighed what we thought about COVID.
When were you first able to visit Sarah in the care home?
I think it was in January. We talked back in November. We got a letter in December talking about visitors could book slots in the visitor centre. Lateral flow tests had just come out then, and they said we could test on arrival. If it was negative, then we could see her for an hour in the visitor centre. So I think we probably applied fairly quickly, but obviously everybody else did, and there were over 100 residents. So I think the first slot we got was January.
And I think, in fact, you wrote to the home and you were able to, at one point, take the lateral flow test before you left because you lived so far away from the home. Is that right?
Well, I took it up with John's campaign. I thought it was ludicrous that we had to drive 3.5, 5 hours on the motorways to the care home to take a lateral flow test, which, if it was positive, we'd then have to drive home, possibly feeling ill. And morally, we couldn't stop at service stations and infect hundreds of people. And I just thought, this is nonsensical. And I wrote to John's campaign talking about the difficulty, because I had the impression they saw all care home residents as elderly people 5 minutes away from their family. And I didn't think they were taking into account people in specialist care homes. And John's campaign told me to write to the Minister for Social Care because she said she didn't think it had occurred to them. And that's what I did, wrote a piece about it for the Minister of Social Care. And guidance was changed to allow people to test before they left home.
In your view, how appropriate were other measures put in place when you couldn't see Sarah for her, so virtual visiting? Was that suitable for Sarah?
It was. We'd never used Skype, Teams, Zoom, whatever before. We had to learn pretty quickly. We realised that talking on the phone just didn't cut it when she couldn't see us. But we felt she was often in tears on the phone to me. Sarah likes the care staff, but she often doesn't talk to them about what she really thinks. Like, for instance, how awful her life is, how awful the epilepsy is, why has this happened to her and not us? So she saves it all up for when she sees me, and then she starts crying. And that is what often happened on Skype. She'd be saying, when can I see you again? And we couldn't answer that question. I couldn't give her comfort. Although she's a young woman, legally, and I recognise that, what she needs is a cuddle when she's upset. And I could not give that to her for over 6 months. And I felt dreadful that she couldn't have the physical comfort that she needed.
Did you feel in those conversations, I think you explained that you felt staff may have been able to hear those conversations.
Yeah.
Did you feel confident that if Sarah did have any concerns about the care or the staff, that she would be able to tell you?
No. Sarah is, I think her underlying intelligence is still there, but it is held back by the profound language problems and memory problems. She cannot remember. She's virtually got no short-term memory, like many people with dementia. So she often can't talk about what she's done today, how she felt this morning, whatever. But she did know that if she talked to me about a member of staff she didn't like, and the person in the room with her was friends with them, it could get back to the person she was complaining about, and they could take it out on her. So that was always a concern of hers all the way through school and college. And so, no, I don't think she would have reported abuse to us in the presence of a member of staff.
At various points, there were rules to do with isolation within the home. And I'm not asking about any particular rule, but generally speaking, what was the impact of isolation upon Sarah?
Well, obviously, she missed the close physical relationship with us. She missed coming home, seeing her brother and sister, our cats. She missed having that outlet for her emotions that she normally had when she comes home and she cries to me every night at bedtime. And often they're questions I can't answer. I can't say why she's got epilepsy. I can't say why it happened to her and not us. But I just try and comfort her and say, look, try and get some pleasure every day from your life. That's what we all have to do. We all have to work. It's boring. So I think she would have been very isolated. As I said, it's like taking a toddler away from their parents, putting them in an orphanage and saying, you can only see your parents once in a blue moon. I think it's the same impact.
And did you notice a difference with her mental or her physical health? Did that deteriorate in any way?
I would say her mental health did. She lost social skills, like, for instance, going to the supermarket, you walk round together in order, around the whole shop. Now, since COVID, she's lost all that idea and she just rushes in and rushes around the shop looking for the things she wants. Same with eating. She will now steal food off our plates, whereas at one time, that would have been anathema to her. She took rules very seriously. And also, I think she has one-to-one care. People telling her all day, you're an adult, Sarah, you can do what you want. And so it's a bit like a spoiled 2-year-old. She wants what she wants straight away. And there is no awareness that you're living in a society, a family possibly, where you cannot do what you want all the time. We have to go out shopping even if we don't feel like it and take her. We can't just say, we'll go without food because you don't feel like going today. So I feel that loss of social skills.
And I think it's right that there was a limitation upon the recreational activities that Sarah could undertake. And do you think that contributed to that as well?
Yes. The care home has a fleet of minibuses. Normally, the house would go out together, and there were trips every day to theme parks, football matches, the theatre, cinema. It was up to her if she went or not, but she could go. There was work experience she could do. She could go to the shop, the gym, play football. All of that stopped during COVID, and really she was kept shut within the house for 2 years. And it was, like watching television, colouring, that sort of thing. I think the lack of exercise was bad for her, and I think she became more isolated in her mentality, not sociable, and her behaviour deteriorated. She was more verbally abusive to the staff and us.
Do you think that there has been any lasting impact of the COVID pandemic upon both Sarah and perhaps upon both you and your family as well?
Yes, I think before the pandemic, she would go out anywhere. If I just said, we've got to go out, such and such place, she'd go. Now, she doesn't want to go out, basically. We have to drag her out and say, you need to go out, you need to get out of the house, you need to walk, so you'll sleep tonight. Otherwise, she can be up all night till 8 in the morning at the care home. We don't have that. We try and do something with her. She gets up at a regular time, has 3 meals at regular times, and she goes to bed when we do. Her life there is chaotic. As I said, she was up till 8 one morning this week. So she woke up at like 6 in the evening, had breakfast, and then talked to us. And I think she got used to being in a room indoors, and now she doesn't really want to go out.
Thank you, Mrs. Lyons. I don't have any further questions for you, but is there anything significant you feel you haven't mentioned that you would wish my lady to hear?
I feel quite often on the news, and the care home would write to us and say, we've sought advice from the Director of Public Health, we're waiting for their answer. They never seem to say, we have also sought advice from consultant neurologists to see how we can balance the needs of the COVID with the needs from her epilepsy. And it seemed like the COVID was the only concern, and her epilepsy, which actually was far more life-threatening, never came into consideration. There was no individual risk assessments. There was no awareness. This wasn't a big care home for the elderly with people living in one big building. People lived in bungalows of about 6 people. And so it was a completely different setup to the average care home. Staffing ratios were much higher. Sarah had 1-to-1, but other people could have 2, 3, 4-to-1. And no allowance was made for that in the public guidance or for people of working age with disabilities who were much healthier than the elderly. There was very little in the media about it. I only saw one news report in the 2 years on a care home that was short of staff and was really struggling. We'd looked at them for Sarah, so we knew them. But in general, there was no consideration. I looked at MenCap, Epilepsy Action's websites. They never really talked about their client groups in care homes until I raised it. I'd write to them and say, your client group is suffering this in a care home. And then they would write a letter for me, which I really appreciate. It's very good of them. But I just felt they were totally left out of government thinking. And no specialist advice was sought. And there was no thinking that we were in our 60s, working from home. My husband is a great bird watcher. So in the afternoons, to relieve our stress, we'd go for a walk in the country. We didn't mix with other people 2 weeks before we saw Sarah. The chance of us giving her COVID must have been remote. And yet the staff could go out to pubs and restaurants. They had school-aged children coming home with all the risks of that exposure that we didn't have. And yet they could spend 8 hours a day with her in her bedroom, and we could see her for about an hour a month behind a perspex screen in full PPE. And to us, it was logical. We were not the biggest risk to Sarah, we felt.
Thank you very much, my lady. No further questions.
Mrs Lyons, thank you so much. Did you ever expect you'd become a campaigner?
No, as my husband said to Lee Day before this, until we had Sarah, we were shy people. We never even complained in a restaurant about bad service or poor food. But we were so incensed at the way the public sector treats the disabled and lies, cheats and bullies families who generally are not aware of the law and their rights, that I spent 20 years studying the law myself, so I knew what Sarah's rights were in certain fields. And I was not going to stand by and see my daughter's life wrecked because other people's major concern was saving money, and I knew all I ever did was use the law to try and get what she was entitled to.
Good for you.
Thank you.
Thank you very much indeed, Mrs Lyons. Sarah's very lucky to have you, but you're very lucky to have her too.
Yes, we are. Thank you very much.
Thank you. I shall sit again on Monday, the 14th of July at 10:30, and next week I shall be chairing the hearings remotely.
All rise.